Thank you, Dr. McNeely, for such a nice introduction. Good morning, everyone, and Happy New Year to all of you. So, today I'll be talking about the management of pediatric neurogenic lower urinary tract dysfunction. So, to begin with, I have no disclosures to make with respect to this presentation or otherwise. So, for today's talk, the learning objectives would be to have an overview of the pathophysiology, etiology, and management options of neurogenic lower urinary tract dysfunction in children, overview of the different management approaches and their differences, and just a few slides about the role of transitional care in pediatric patients with lower urinary tract dysfunction. So, talking about the lower urinary tract first, we all know that it consists of two functional units with the urinary bladder acting as a reservoir and the bladder neck, urethra, and the two sphincters forming the outlet. The two main physiological functions of the lower urinary tract are low pressure storage of the adequate volumes of urine and periodic complete voluntary expulsion from the bladder in a coordinated manner. Now, the coordination between these two is mediated by a complex neural control system located in the brain, spinal cord, and the peripheral nerves. Which brings us to the innervation of the bladder. It is supplied by three nerves: the pelvic, hypogastric, and the pudendal nerve. The pelvic nerve, it has both the sensory and the parasympathetic fibers. The sensory fibers, they pick up the stretch from the stretch receptors as the bladder fills and conveys it to the sacral portion of the spinal cord, which then sends the parasympathetic fibers. And these fibers, they release acetylcholine, which act on the muscarinic receptors and cause contraction of the detrusor. The sympathetic fibers, they go via the hypogastric nerve from the lumbar portion of the spinal cord, and they act on the beta 3 receptors on the detrusor muscle, resulting in the relaxation. And at the same time, they also act on the alpha 1 receptors on the internal urethral sphincter to cause its contraction, thus allowing to accommodate large volumes during filling and the storage phase. The pudendal nerve is the somatic nerve, and it provides innervation to the external urethral sphincter and is under the voluntary control. It prevents the bladder emptying. Micturition occurs involuntarily in infants and young children until the age of 3 to 5 years, and at this time of life, it is only controlled by the autonomic portion of the spinal cord, which is the autonomic spinal cord reflex. But as the central nervous system matures, this reflex is influenced by the higher centers in the pons, which is called the pons micturition center, and the suprapontine centers in the cerebral cortex, primarily in the prefrontal cortex. Now, this pons micturition center, it acts as an on and off switch, and by default, it triggers the voiding reflex. But when this center, it receives sensory signals from a full bladder, it communicates it to the cortex about the appropriateness of the urination at the moment. But when it's not convenient, the center, it sends back the inhibitory signals to keep the sphincters closed and prevent the voiding. So it switches off the pontine micturition center. And when we wish to urinate, the cortical inhibitory signals, they are removed and the PMC triggers the voiding. Thus, a coordinated control between the brain, spinal cord, and the bladder, it results in proper storage and micturition. And any disruption in this pathway can lead to lower urinary tract dysfunction. So, the neurogenic lower urinary tract dysfunction, it refers to the abnormal function of the bladder, bladder neck, and or sphincters caused by the injury or disease of the central and the peripheral nervous systems, which leads to problem with the adequate storage and elimination of the urine, which can lead to inability to empty the bladder, recurrent UTIs, long-term renal damage, and incontinence, compromising the quality of life. Coming to the etiology, it can result from multiple conditions which affect the spinal cord, brain, or the peripheral nervous system. The most common cause is spinal dystrophism in children. Other underlying conditions, they include sacral agenesis, caudal regression syndrome, anorectal malformations, cloacal malformations, and other injuries like spinal cord injuries or transverse myelitis. The pediatric neurogenic lower urinary tract dysfunction is increasingly prevalent in India, in Canada, although the exact prevalence of the neurogenic lower urinary tract dysfunction is not known. But a population-based study conducted in Canada from 2004 to 2015, it showed that the prevalence of neural tube defects as such has increased from 3.6 to 4.6 per 10,000 in 2015. And specifically of all the neural tube defects, it was the spina bifida, which has shown the increased prevalence over the time, which kind of tells us that there are many patients here with neurogenic lower urinary tract dysfunction. There are various ways to classify the neurogenic lower urinary tract dysfunctions, but irrespective of the neurological level of the neurological lesion, the urodynamic and the functional classifications are much more practical for defining the lower urinary tract pathology, risk stratification, and planning the treatment in the children. So the both detrusor and sphincter, they may be either overactive or underactive, resulting in the four different combinations. And of all these four types, the combination of sphincter as well as a detrusor inactivity is inherently safe in a sense that if left untreated, it will not lead to the upper urinary tract damage, although it does result in incontinence and increased rates of UTIs. Coming to the diagnostics, the renal dysfunction in patients with neurogenic bladder is often silent, necessitating the need for regular surveillance and imaging of the upper urinary tracts. Renal bladder ultrasound is the most frequently obtained study to detect these anomalies and follow the trends over the time. However, of note, minimal or absent hydronephrosis on the surveillance scans, they should not provide us complete assurance, as in many of the studies, including the one by Sager et al., it was found that although only one-third patients, they had pelviectasis on the ultrasound, but nearly 50% of them had high-risk urodynamic parameters. The urodynamic studies, these are the most comprehensive tests to evaluate the bladder dynamics during storage as well as emptying. They provide us information about the compliance, capacity, storage and leaking pressures, neurogenic detrusor overactivity, and the voiding inefficiency. There is this assessment that helps us to stratify children with the intent to intervene in the patients who are at the high risk of progressive bladder dysfunction, the so-called hostile bladder, which is defined as the poor bladder compliance, who have high storage pressures and detrusor sphincter dyssynergia. However, it may be challenging to obtain the urodynamics in very young infants because it requires to be still and there is catheterization required, the periurethral and the rectal catheterizations. So that is one thing. But given the valuable information regarding the bladder parameters, it is very important to establish the baseline function in the childhood so as to inform a patient care's trajectory in the short term. Voiding cystourethrogram as a standalone test, it has a limited value as it provides only with the anatomic information and about the appearance of the bladder and urethra and the presence or absence of reflux and allowing for assessing the bladder capacity and the post-void residual. However, when it is combined with the urodynamic studies, the so-called the video urodynamics, it gives us a real objective information about the volumes and the pressures at which this reflux or the urinary leak is happening, thus giving us a more detailed information that helps us in treatment planning. Before we discuss the various treatment modalities that are available, I would like to discuss the two treatment approaches for the patients, especially those with spina bifida, the reactive approach and the proactive approach. Now, the proactive management, as the name suggests, it takes a preventative approach in which the interventions, they are initiated prior to the onset of any renal changes. So in this approach, a baseline urodynamic study, it is done in the first months of life only, regardless of any clinical or imaging findings, to stratify the risk of bladder hostility. And as such, the CIC that can be initiated even at birth or in response to the abnormalities on the early urodynamic study that is done, and then it is continued based on the bladder function. Similarly, pharmacotherapy that it may also be initiated in response to the urodynamic and the imaging findings. Finally, renal sonography and laboratory tests, including serum creatinine, they are regularly and frequently performed in these in this approach for the surveillance. In the expectant approach, on the other hand, although the renal bladder ultrasound imaging, that is the one that is completed as a part of initial assessment and is repeated on follow-up surveillance scans. But the invasive diagnostics such as urodynamics, they are not routinely performed unless other findings suggest upper urinary tract changes. And a formal urodynamic evaluation once done, that determines whether to go for CIC or anticholinergics. But out of these two approaches, which one is optimal is still not well defined. The proactive approach, it is based on the premise that most patients with spina bifida, they are born with normal kidney function. Only 5 to 10% of them have dysfunction right at the birth. So any subsequent deterioration should be considered preventable, and thus more aggressive approach would prevent or delay the upper tract and the bladder damages, and theoretically would decrease the chance of augmentation and the eventual surgeries that are required. Moreover, the main premise for this also is that early intervention, it improves the compliance and acceptance of the clean intermittent catheterization in parents and the children, because eventually many of these are going to require CIC when they are later in their life, when they undergo augment or other procedures. The expectant approach, on the other hand, has the advantage that it avoids the overtreatment of the non hostile bladders and saves families and patients from the psychological stressors and morbidity associated with intermittent catheterizations and medical therapy. But it could risk the upper tract damage, and initiating CIC at older age could be difficult for some patients if they've not started it early on. Thus, the two approaches, they are at the opposite ends of the spectrum of the management, and some practitioners they like to fall somewhere in between, practicing a more hybrid approach. There have been various studies conducted to support the two management approaches, but they provide low level of evidence, as most of these studies are biased and confounded. If we talk about the urodynamics itself, as I earlier mentioned, that proponents of each strategy, they differ in their belief in the diagnostic utility of the baseline UDS and its role in guiding the management. In one of the studies performed by Bawa et al., he favored the proactive approach by showing that 80% of the patients, they had abnormal urodynamics without other clinical imaging or laboratory abnormalities, suggesting that baseline UDS may detect abnormalities that would otherwise have been missed with the expectant paradigm. Another retrospective study by Costa et al. Compared improvements in the urodynamic parameters between the children who got the test done before their first birthday to those who got it done later in their lives. And they found that there was a 3.5 times higher chance of improvement in the bladder capacity, compliance, and pressure for the children who got it done before first year of age than those who got it done later, providing another compelling support for the proactive management. In contrast, the proponents of the expectant management, they contend that early UDS has limited utility and clinical relevance. In a study of 335 patients, Tishman et al., they demonstrated equivalent renal deterioration rates among the patients with favorable versus the impaired results on urodynamic studies in spina bifida patients, thus concluding that abnormal urodynamic parameters were not associated with renal deterioration, including hydronephrosis, renal scarring, cortical thinning, or elevated serum creatinine. Hobson group in 2003 also demonstrated the success of expectant approach by showing that renal deterioration occurred only in 1.2% of the renal units which were managed with the expectant video urodynamic study. The initiation of CIC, that's another central difference between the two paradigms. And to support the proactive management, there's a prospective study by Ellenstein et al. In 1995 that compared the upper tract changes of the children managed with proactive CIC to a historic cohort, which was managed with expectant CIC. And they found that the patients with proactive CIC had lower incidence of the upper tract changes. These findings were reproduced by Elzanini in 2019, who showed that patients with proactive CIC had less renal scarring on DMSA than the ones who were doing it expectantly. But the expectant group, they initiate CIC only after the development of clinical imaging or UDS abnormalities. Timberlake et al. In 2017, he compared the renal outcomes in children who started CIC before 1 year to the ones who started it after 3 years. And he found that DMSA abnormalities, they appeared only in 3.4% of the patients who were managed expectantly. He also found an association between CIC and the bladder dynamics and the febrile UTIs. He found that CIC was associated with increased rates of febrile UTIs in patients without trabeculations. If, however, the bladder was trabeculated, the CIC decreased the chances of febrile UTIs, thus suggesting there's a relationship between UTI and CIC. It depends upon the bladder characteristics. Wu et al. In a study on myelodysplastic patients identified early CIC as a risk factor for renal damage, defined by both DMSA scarring and VUR and increasing hydronephrosis. Early CIC was associated with a significant increase in the renal damage, and there was a deterioration in the renal function as well. Sager et al. In 2017, they compared outcomes of the proactively managed pediatric patients presenting with spina bifida at 12 to 18 months, and then they followed up this patient again at 5 years of age, and they found that although there was decreased UTI and VUR, but higher number of patients had DMSA abnormalities and reduced bladder compliance. However, this study there was no comparator group in the study, so how much the results are reliable, it's not sure. So, which is the optimal? Although there has been a trend towards a proactive or early approach based on the increasing evidence from these retrospective cohort studies supporting the proactive approach, but deciding which one is better or optimal is still difficult because most of the studies they have moderate to serious risk of bias, and due to retrospective nature of most of these studies, patient selection bias has not been addressed. There's lack of standardized reporting in literature, lack of randomization in observational studies, and there's also lack of standardization in terms of defining what is the proactive versus the reactive management protocols across the studies. Whichever approach we follow, the primary urological goal of management are the preservation of the upper tracts, the renal function, prevention of the febrile UTIs, and achievement or improvement of the continence and maximization of the urological independence and quality of life as appropriate. These goals, they keep on evolving with the age of the patient. And to preserve the upper tracts, we need to address the bladder dynamics and we need to do the bladder management. So the pediatric patients with neurogenic lower urinary tract dysfunction, they present a challenging treatment group due to changes in the bladder function that can occur throughout their life. And treatment, it usually begins with the conservative methods and focuses on achieving safe bladder pressures during storage with reliable emptying via voiding or catheterization and pharmacological treatment of the functional disorders. So talking about the clean intermittent catheterization, it was Dr. Jack LaPage who popularized the concept of clean intermittent catheterization over sterile intermittent catheterization. And since then, CIC remains the preferred method of management, and it helps by eliminating the post-void residual volumes, reduces the elevated bladder pressure, and thus prevents the complication and saves the upper tracts and improves the urinary incontinence. However, the repeated catheterization, they are fraught with traumatic catheterizations and complications like false passage, strictures, and meatal stenosis. Hydrophilic catheters can help to decrease the hematuria and the stricture rates. But in addition to that, it can also be challenging for certain group of patients to perform these CICs, especially the ones who have upper extremity motor impairment, or in case of non-ambulatory female patients, from a positioning standpoint, it might be difficult. UTIs are one of the greatest concerns and also one of the main reasons for non-compliance in this group of patients. So, to date, 8 randomized trials and 1 meta-analysis of the same data have compared symptomatic UTI rates in individuals using single catheters versus those using recatheters, and there was no difference seen in the symptomatic UTI rates between the two, so the reused catheters can be used. Another study comparing the hydrophilic versus the non-coated catheters. However, this was a meta-analysis of 9 studies in which there were 4 pediatric studies, and overall the use of hydrophilic catheters had a lower risk of UTIs, but when it was seen particularly in the pediatric population, there was no significant risk reduction in terms of UTI or hematuria. The second tool in the conservative treatment of a child with neurogenic lower urinary tract dysfunction is the pharmacotherapy. Antimuscarinics or anticholinergics, Uh, they represent the mainstay of the pharmacological treatment, and they block the muscarinic receptors in the bladder, and which are responsible for causing the detrusor contraction. And oxybutynin, this is the first formally approved FDA anticholinergic for children. And in addition to its antispasmodic properties, it also has local anesthetic and calcium channel blocking properties that augment the effect on detrusor overactivity. However, it is non-specific and it acts on both the muscarinic receptors in the bladder, the entry receptors, and the M1 receptors, which are found on the salivary glands, intestinal sympathetic ganglia, which are responsible for most of the side effects that include blurry vision, dry mouth, constipation. But overall, they are less frequent and bothersome in children. But many of the patients, they are intolerant to these side effects and have to look for some alternative treatments. Intravesical oxybutynin that has been evaluated for its potential to decrease these side effects by reducing the first pass metabolism in the liver, because it is one of the metabolites of the oxybutynin that is responsible for all these side effects. And the intravesical can maintain high systemic efficacy and bioavailability also. Solifenacine is a new anticholinergic medication and is more selective to the bladder. Thus, it provides a more favorable systemic side effect profile. And it also requires only once daily dosing and is effectively safe. In the children showing intolerance to the side effects or lack of efficacy to the oral antimuscarinics, endoscopic administration of Botox that should be considered as an alternative. It works through a completely different mechanism of action. It basically doesn't deal with the receptors, but it blocks the presynaptic release of the acetylcholine. And it reaches when given, it reaches the maximum efficacy levels at around 1 month, but the effect, it lasts for only 6 to 9 months, which means repeated injections. But the need for anesthesia in younger children, because we do it under anesthesia only, and that's one of the most important concerns with this intervention. And many recent trials and systematic reviews, they have suggested the safety and efficacy of Botox in pediatric patients with refractory neurogenic lower urinary tract dysfunction, with the most commonly reported outcomes being improvement in the incontinence and UDS parameters like detrusor pressure, bladder capacity, and compliance. Myrabagron, that's a new class of drug that relaxes the detrusor smooth muscle during the storage phase by activation of the beta 3 receptors, which increases the bladder capacity. It has been approved by FDA in pediatric patients more than 3 years of age with neurogenic detrusor overactivity, but it's still used off label, and it has side effects like hypertension, headache, and dizziness. So, given this blood pressure should be measured prior to and shortly after the initiation. A recent retrospective study, it evaluated the efficacy and long-term outcomes of mirabegron given as a solo or as an add-on therapy in children with refractory neurogenic lower urinary tract dysfunction who were refractory to other drugs, other treatment therapies like antimuscarinics and botulinum toxin. And it was found that there was a statistically significant improvement in the incontinence and urodynamic parameters. And it was found that on sub-analysis of the 20 children with low compliance, they showed an even greater improvement in the urodynamic parameters after the myrapegron was given. They also did a separate analysis on the add-on therapy group and found that as opposed to an add-on therapy group, the monotherapy group only showed improvement in the bladder compliance. And 93.3% of the monotherapy group, they needed some kind of additional therapy in addition to the mirabegron, while as those who were already on one of the therapies, only 36% of them required an add-on therapy. So thus, there has to be like a patient selection when we are giving mirabegron. So especially the ones who have lower compliance or who are already on one, this may show more effects. Alpha blockers in the sphincter and the bladder neck muscles, there's presence of these alpha 1 adrenergic receptors, and their activation, it increases the sphincter mechanism tension, and their inactivation, it enables the voiding. So these alpha blockers, they block the alpha 1 receptors and reduce the sphincter tension and eliminate the functional obstruction. Their use is also off label still in pediatrics, and side effects of hypotension, dizziness, and drowsiness, they must be considered before considering these drugs. While most children, they can be managed with the conservative therapies, and always the conservative therapies are started initially, but surgical interventions, they may be necessary when there is evidence of upper tract deterioration, recurrent febrile UTIs, and failure to achieve continence despite maximal medical management. And it is important to remember that surgery does not eliminate the need for the intermittent catheterization. In fact, it becomes more crucial after this surgery, especially when we are doing augments or bladder neck procedures, which alter the dynamics of the bladder. Continent catheterizable channels. So it was Paul Mitrofanoff who used the appendiceal conduit in 1980 for the first time, and this may be offered to selected school age or adolescent patients who have difficulties performing intermittent catheterizations via the urethra, and it provides a good overall quality of life and associated patient satisfaction. However, it does not replace the need to manage the bladder pressures. So, compliance with doing the intermittent catheterizations is very important. Sometimes we might have to resort to incontinent diversions like vesicostomy for the hostile bladders in children who are unwilling or where the parents are unable to perform the CIC reliably due to anatomical or social reasons. Cystostomy button may be an alternative, but it acts as a temporizing measure, and the reported complication rate has been around 34% in many other studies, and it's mostly UTIs related to the cystostomy button. Cutaneous ureterostomy is another form of incontinent diversion that can be a surgical alternative in the setting of high-grade vesiculotic reflux and recurrent febrile UTIs and a poor bladder dynamic that precludes the consideration of vesicostomy. Overall, these are incontinent diversions. They need to be reserved for infants prior to the typical toilet training age, and less commonly in older children. Bladder augmentation, this is considered as a last resort and is offered in cases where anticholinergic drugs and Botox injections have failed to maintain a low pressure reservoir with a good capacity and bladder compliance. Or this can also be offered for continence as the patients, they increase the age. So this increases the need for intermittent catheterization, and in those who are not able to perform it transurethral, Mitrofanoff that is added as a procedure, and it has been seen that in the long term, it is more cost effective than Botox therapy for patients who are likely to benefit from incontinence treatment for more than 10 years. In a recent systematic review and meta-analysis conducted by Rees et al. That investigated the clinical and urodynamic findings in children and adolescents with neurogenic bladder undergoing augmentation cystoplasty, it was found that it leads to substantial reductions in the urinary incontinence rates, with success rate ranging from 76.5 to 91.3%. And a specific study that compared the improvement rates between the patients who underwent augmentation alone and to the ones who had augmentation as well as the bladder outlet procedure. This study concluded that there was no statistically significant difference in the rates of improvements in urinary incontinence between the two groups. The resolution rates of VUR, they varied across the study from 12.5 to 64%, and there were significant improvements when the reimplant was included in the surgical approach as well, and the bladder function was markedly improved with urodynamic parameters like bladder capacity and compliance showing an increase, and drop in the end feeling pressures. Despite its impressive bladder outcomes, and this and many other studies in the past, augmentation cystoplasty, it comes with significant short and long-term risks, which depend upon what segment of bowel we are using. And these include bladder calculi, UTIs, mucus production, bladder perforation, metabolic and electrolyte disturbances. So it's very important to do the long-term surveillance and ensure that CIC compliance is there to prevent and manage these risks. Bladder saline flushes are recommended 2 to 4 times a day to prevent the mucus accumulation, UTIs, and the stone formation. As pointed out at the beginning of the talk, though a weak or insufficient bladder outlet is a safe situation from the upper urinary tract perspective, but this may become an increasing social problem due to persistent incontinence, and it's a major challenge for the pediatric urologist to increase the bladder outlet resistance. So far, there is no pharmacological treatment that has been validated to increase the bladder outlet resistance, and it is important to recognize that treating incontinence in patients with neurogenic lower urinary tract dysfunction can be associated with upper tract deterioration, particularly if the bladder pressures are high. Therefore, it's very important to do the bladder pressure flow evaluations before in the pre-operative assessment, and likewise the post-operative surveillance is also very important and should be maintained because subsequent augmentation cystoplasty that may be required if the bladder condition is hostile and the upper tract is at the risk. Many a times these procedures are done along with the augmentations as well. So we have various options. The first one is the injection of the bulking agents. It was Wassman et al. Who started using polytetrafluoroethylene first of all, but now it's mostly deflux and microplastics that are used. This can be done endoscopically and can be done in an antegrade manner because most of these patients they have mitrophin off channels, and or in those in whom there is no mitrophin off channel, this can be done through a suprapubic puncture or can be done retrogradely through the periurethral route, or there can be a combined approach, and 10 to 40% success rate has been reported. There is no negative impact on the outcome of the future continence procedures if they have to be done, but the success of the bulking agents as such, it reduces after the previous bladder neck surgery. But it is still questionable as a first-line treatment for the pediatric patients. Coming to the slings, the evidence from the NICE guidelines and European Association of Urology has shown that autologous fascial slings, they increase the bladder outlet resistance and improve the continence rates by 40 to 100%, but they may be associated with catheterization difficulties and risk of damage to the surrounding structures. The most recent and the extensive review conducted in 2023 by Teskin et al., he compared the efficacy of the bladder neck procedures in the augmented bladder patients, and he reported a continence rate of 57% in the patients, which is higher than that achieved with the injectable patients, but lower than that with the bladder neck procedures or closures. Artificial urethral sphincters, although it is currently the standard treatment for the adult patients with stress urinary incontinence, but they are less well established in children, and ideally they have to be done in the post-pubertal individuals who are capable of spontaneous voiding and possess the manual dexterity to operate the sphincter pump mechanism, and should be offered to such patients only. And they were quite popular in 90s in the pediatric age group as well, and they were done. A lot of artificial urethral sphincters were inserted in sick kids Toronto, but because of the associated complications and changes in the bladder dynamics, this has fallen out of favor now and is not very popular. Miguel et al. In a retrospective study in 2022, he evaluated 71 patients in which the artificial urethral sphincter was inserted for the patients with congenital neuropathic bladders, and he reported the urinary continence in almost 90% of these patients, with the 9 patients voiding spontaneously and 62 requiring CIC. They reported an average working life of 15 years for these sphincters, and in 21%, these sphincters had to be removed because of the malfunction. Bladder neck closure with a continent catheterizable stoma. This is often seen as a last resort to gain urinary continence in those with persistent urinary incontinence. There is a complication rate of up to 33% has been reported, with vesicourethral and vesicofistula occurring in up to 15%. But the consideration this employs careful patient selection and understanding the risks of each, such as upper renal deterioration and bladder rupture in cases of poor adherence with the regular bladder emptying. Coming to electric stimulation, there are various trials and reports on the use of neuromodulator therapy in neurogenic bladder patients, but to date, there is insufficient evidence to support the use of these electrostimulation of bladder, sacral nerve stimulation, and transcutaneous neuromodulation for the pediatric patients. Coming to the transitional care. So historically, the children who were diagnosed with neurogenic bladder, they experienced significant reduction in life expectancy, most commonly due to the development of renal failure. But with the advent of these management options like CIC, antibiotics, and augments, most patients today survive well into adulthood. In Canada alone, there are 350,000 patients living with spina bifida, and this extended life expectancy, it carries many implications. As the patients age into adulthood, they are typically required to transition care to the adult urologist, but this poses a significant challenge for the patients as well as the providers alike, because most of these patients, they have other complex medical diagnoses requiring management by the multiple specialists, which they receive in multidisciplinary clinics as pediatric patients, but then their management that becomes disjointed when they enter into the adult world. They have undergone extensive surgical. There is an extensive surgical history to most of these patients with altered anatomy requiring specialized knowledge, and there is increased expectations in the patients also and their families also with respect to the quality of life as they become adults. And there is also an adjustment required in the medical management part as these patients, they progress through adolescence into the adulthood, often aging out of the pediatric providers and clinics, requiring transition to adult providers and clinics. And failure to make these transitions, it leads to interruptions in care and increases the preventable complications. In 2015, the American Urological Association, in its first ever working group on genitourinary congenitalism, it emphasized the importance of transitioning to the health services and acknowledged that failure to make these transitions can lead to interruptions of care and increases the preventable complications. In a study published by University of Oklahoma, they evaluated their single specialty transition program for patients with congenital neurogenic bladder over a period of 9 years. In their program, the transition that happens through 4 stages. In first stage, the patients, they are introduced to the transition process, and their assessment for the transition readiness is made based on several questionnaires. In the second stage, the adult urology providers, they are introduced to the patients by the pediatric urology providers. And in the T3 patients are the ones who are seen by the adult urology providers, but in the pediatric urology clinics. And T4 is the complete transfer of care. So in this study, there was another group, which was a T4X group. These were the patients, the de novo adult patients who attended the adult urology clinic without any formal transition from the pediatric urology clinic. And of the 157 patients who were attending the transition clinic, 79 of them were deemed fit for transition in the T3 appointment based on their readiness. And of the 79 selected patients, 76, they successfully transitioned to the adult world. And there was a 69.6% overall success rate, which was defined as attending the appointment at least once in every 365 days. And they found that the active follow-up, it was the highest for the fully transitioned patients, and inactivity was highest during the pediatric stage when they were just introduced to the idea of transition. They also found that those patients who were non-transition and directly attended the adult urology clinic, they initiated their adult urological care later than their transitioned counterparts, almost by 10 years. And on comparing the transitioned to the non-transitioned patients, it was found that in both the groups, the greatest attrition rates were seen during the first 2 years, and there was higher participation rates in the transitioned patients at each given point of time than the non-transition patients. However, the non-transition patients, they followed up for a longer period of time, and 72% of the transition patients compared to 36% of the non-transition patients remained actively managed. And although the inactivity reasons that remained similar in they remained almost similar in both the cohorts, with non-compliance being the most common reason for showing the inactivity. So finally, they concluded that the factors that contributed to the successful transition was the early introduction to the adult urology providers, increased number of appointments during the active transition stages from T3 to T4, and early interaction with adult urology providers, and direct involvement of the nursing managers. So to conclude, the goals of the management, they evolve with time for the pediatric patients with neurogenic lower urinary tract dysfunction. Surgical management often needed for the failed medical treatment, and the proactive versus the expectant approaches. The more studies, more prospective and randomized studies are required to solve this, and lifelong follow-up is needed in patients with augment cystoplasty, and transitional care is important. Thank you.